Good afternoon, everyone. We are about to start our afternoon sessions. So we have 4 oral presentations, 2 state-of-the-art lecture this afternoon. So the first 4 presentations will be moderated by Dr. Bethel Dorje and Dr. Kidan Abraha. So Dr. Bethel is an assistant professor of obstetrics and gynecology at St. Paul's Hospital Millennium Medical College. She had both her undergraduate and postgraduate studies at Addis Ababa University. She did her subspecialty training at St. Paul. Currently, she serves as a resident program director and coordinator of the Gynae Oncology Fellowship Program at the same college. Dr. Bethel is also a general manager of WeCare Digital Health program. She had served as a lecturer, undergraduate program coordinator, and an assistant dean of St. Paul Hospital Millennium Medical College. She was also one of the female physicians to realize the Ethiopian Medical Women Association and served as an executive board member of the for the first year. She was also an active member of ISOC in the examination and certification subcommittee. Apart from her professional activity, she delivers her social responsibilities in teaching high school students, leading outreach programs for orphanages, and as a board member of the Addis Ababa City Administration, a school feeding program. Dr. Bethel is also a proud wife and a mother of 4. She is she's passionate about mentorship and gender equity. As a hobby, she enjoys gardening. Please welcome Dr. Bethel Dorje. The second moderator is Dr. Kidan Abraha. Dr. Kidan is an assistant professor of reproductive health and public health at St. Paul's Hospital Millennium Medical College School of Public Health in the Department of Reproductive Health. She obtained her PhD degree in 2012 with a joint program of Mekelle University and Addis Continental Institute of Public Health, and her master's degree in reproductive and family health from Addis Ababa University in 2010. She has more than 8 peer-reviewed publications and 2 conference presentations. Please welcome Dr. Kidan to the stage to moderate the sessions.
Thank you, Makte, for the warm introduction. Good afternoon, everyone. So now we will start our afternoon session. We understand that there is great sympathetic stimulation, parasympathetic stimulation in the afternoon, but we will try to cope up since we are far behind our schedule. Our first presenter will be Professor Ernestina Costa. Ernestina Costa is a professor of health and international development at the London School of Economics. Her research is in multidisciplinary and used mixed methods to understand the relationship between context and sexual reproductive health. She was the principal investigator of the research project entitled Improving Adolescent Access to Contraceptive and Safe Abortion in Sub-Saharan Africa. I will call upon Professor Ernesta for her presentation.
Hello, my name's Ernestina Coast, and I'm here to present our team's work looking at adolescent contraceptive and abortion-related care seeking in 3 urban settings in Ethiopia, Malawi, and Zambia. And I want to extend a thank you to the organisers of the 4th Symposium for the invitation to present our work here. I'm really looking forward to any questions that you may have or any follow-ups about the findings and the implications of our research. I'm presenting on behalf of a large team. A piece of work of this scale involves a large team of people across multiple countries and institutions, and also obviously our funders. So let's set the scene. What do we know about adolescent sexual and reproductive health care seeking? We know that adolescents are much less likely to access abortion services relative to older people. And this is for a really wide variety of reasons. Adolescents tend to have lower levels of knowledge about many things related to their sexual and reproductive health, including recognizing whether or not they're pregnant, including understanding how they become pregnant, including understanding their ability to access or negotiate contraceptive use. Adolescents also have fewer financial resources on average compared to older people. Many adolescents are still in education, for example. Adolescents tend to have a much higher likelihood of delaying care seeking if they want to seek an abortion. And that's often linked to a much lower ability to navigate health systems in a range of different legal and health system contexts. For many adolescents, seeking care related to contraception or abortion may actually be the first time they've had to independently attempt to navigate a healthcare system. And we also know that across the world, there are much higher levels of both perceived and experienced stigma that adolescents experience compared to older people, linked to assumptions and norms about adolescent sexuality and how adolescents should be behaving. So our research project set against this broader context is really focused on understanding the experiences of adolescents as they tried to navigate access to contraception or abortion-related services. So we're really trying to understand the individual level experiences of adolescents in these three settings. But we're situating these individual experiences in the broader structural context, the legal frameworks, the health system frameworks, and understand how these macro level factors are implicated in adolescent abortion-related care seeking. So let's just set the scene and to help understand why we selected these three countries. This is a table that is showing us the headline differences between the three contexts: Ethiopia, Malawi, and Zambia. And in many ways, these three countries represent different points in a continuum in terms of the legal restrictions around abortion, particularly, but not only for adolescents, but also the availability of safe abortion services. At one end of this continuum, in Malawi, the legal context is highly restrictive. So life of the pregnant woman is the sole determinant of access to safe and legal abortion services. Alongside this, there's very limited availability of safe abortion services. In Zambia, which has much broader grounds, legal grounds for the provision of abortion services, established for over 40 years, we see some availability across both public sector facilities and some limited availability in the private or NGO sector. And at the other end of the continuum, Ethiopia, with a broad range of legal exemptions for abortion and widely available safe abortion services in the public, the private, and the NGO sectors. So that sets the macro level scene for our study. We used a wide range of research methods, including a comparative policy analysis, stakeholder interviews, and interviews with adolescents. And what I'm really going to focus on here today is the evidence from the interviews with adolescents. So these are adolescents who had sought either safe abortion or post-abortion care for an abortion initiated elsewhere in public facilities in urban settings in the three countries. And in total, we interviewed over 300 adolescents. And on this slide, you can see detail on the numbers of adolescents we interviewed. I'm very happy to give more detailed information on our methodology and how we went about collecting this evidence. I just want to draw your attention to the availability for all of our research instruments on our project website. But what I want to focus on is the evidence that we've identified. So let's look at the headline results across the 3 countries, looking at the percentages of adolescents who sought and received safe abortion at the facility where we did the interviews. And this ranges in Ethiopia from 98% of the adolescents that we interviewed through to just 4% in Malawi. In Zambia, 34%. So we can see very clearly that relationship between the macro systems, so the legal and the healthcare systems, and the outcomes for individual adolescents. If we take a look in more detail at the type of abortion-related care that was sought in each country, we see that 98% was safe abortion at the interview facility in Ethiopia, 2% seeking post-abortion care. Let's compare that to Malawi, where nearly 100% of care was post-abortion care at the interview facility. And in Zambia, reflecting both the legal context and the availability of services, we see a more mixed picture. Whilst we're focusing on the outcomes for adolescents and describing their experiences, we think it's important that we also reflect upon and understand, what does it mean for an adolescent to achieve an abortion? And on this slide, we can see a range of quotes from all 3 countries about the meanings and the emotions attached to seeking and receiving an abortion. We see expressions of relief. We see the linkages with adolescents and their aspirations, for example, of education in the future. And we also see some of the articulations in the final quote from a 15-year-old that we interviewed in Ethiopia around her suicidal feelings related to having an unintended pregnancy. So what we want to do now is take a look in detail at what it means, what are the pathways, what are the trajectories that adolescents in these 3 countries take. So the next slide, I know it looks very busy, but let me explain it to you. The data from Ethiopia is in yellow, from Malawi is in red, and from Zambia is in green. And on the left-hand side, we have an individual starting their pathway. On the right-hand side, we have the end of that pathway. And what we are doing is looking in detail at where adolescents went first. So what do we see? We see in Ethiopia that the overwhelming majority of adolescents went directly to a health facility, compared to Malawi, where the majority first had an unsafe abortion attempt and then went to a health facility. So we see the detail of individual trajectories, and it helps us to start to understand how adolescents are able to or are engaging with the health systems in their individual countries. So what are some of the key issues that we want to draw your attention to? Well, first of all, the delays. We know that abortion-related care seeking is time critical. And a key theme throughout our evidence was delays in seeking and receiving abortion care. The lowest proportion of adolescents who reported a delay in seeking care was in Ethiopia. That's the blue bar. The highest proportion was in Malawi. So let's focus in on Ethiopia. What's really interesting about Ethiopia is that the most common response from adolescents was that they did not know where to seek care. So that gives us important information about gaps in information provision. I'm going to focus on, because of the site of this symposium, I'm going to focus on some of our qualitative evidence from Ethiopia throughout. And we see very varied reasons for the delay. We see in the first quote that an 18-year-old received a very negative reaction, a very stigmatizing reaction when they first sought help in the public health sector in Ethiopia. In the second quote, we see how fear and being afraid really contributed to this individual's delays. And in the third quote, we see the very low levels of understanding or acknowledgement of a pregnancy and a very common issue of adolescents just hoping that they weren't pregnant. We also see delays being introduced within the health system, with adolescents being asked to return with a guardian to carer or a parent, even though the law and policies support the autonomous choice of legal abortion for minors. But we can see that there are some providers that do not enact this policy. If we take a look in detail about what adolescents told us about their use of contraception, so these are all adolescents who had sought abortion-related care, we see that over 4 in 10 of girls at some point had ever used some form of contraception. Under a quarter reported using a method when they became pregnant with the pregnancy that then resulted in an abortion. Similarly, whilst almost half of adolescents reported that they'd heard about emergency contraception, whilst 1 in 8 had tried it for the pregnancy that just ended in abortion, none of those were successful. So this gives us important information about, for example, the role of emergency contraception and the needs of adolescents and the access to emergency contraception provision. If we look in particular at the barriers to contraceptive use, we saw a very common issue around adolescents not having the agency to negotiate contraception with partners, specifically when sexual violence and coercive sex were implicated. And we see several instances of the ways in which sexual violence and coercive sex were implicated in the non-use of contraception. But let's think about post-abortion contraception. Across all 3 countries, we see in the interviews with adolescents that frequently they weren't given any choice. If we look at the quote from Ethiopia, this adolescent is saying very clearly, I don't want it. A nurse told me that I have to use contraception. She wouldn't understand me. She considered me as a rude girl and treated me badly. And we do see some evidence of the ways in which post-abortion contraception was being coercively used. And in this example, we see an adolescent discussing how they were really concerned that their abortion care would be withheld if they didn't accept a certain form of post-abortion contraception. So what are the implications of our results? That health systems need to support the provision of zero-cost care. We know that adolescents have much lower access to financial resources in order to access care. Throughout our findings, we see in many cases very low levels of knowledge and information about everything from whether or not they are able to access contraception, whether they are able to negotiate contraceptive use, if they decide they want an abortion, how to seek abortion-related care, and overall, that policies and legislation really need to account for the specific experiences and needs of adolescents. Now, we know that it's not enough just to disseminate our research to policymaker and research and practitioner audiences. So we have also developed some animations and comic books in order to communicate our research to adolescents. Please do get in touch if you'd like copies of any of those. We've also developed country level policy briefs, again, which are available to use and to download. Please do get in touch if you would like any copies of these. We do have some publications to date from our research in the academic literature. Most of all, thank you for your engagement with our presentation, with our work. We want it to be useful. Please do get in touch. We'd love to hear from you.
Thank you, Professor Ernestino, for the excellent presentation and to bring the impact of safe abortion care in Ethiopia and to see the informed choice of our clients and the extent of respecting the autonomy of our clients has been presented in this presentation. So I will call upon, I will open the floor for comments and questions for Professor. Since she has been waiting online for the past 2 hours, we should collect some questions from her, from the audience, and we will pass to the next presenters. Brooke, do we have any questions online? I think if we don't have any questions, we need to proceed to the next presentation since we are lagging behind from the schedule. Okay, so thank you, Professor, for the excellent presentation, and we will proceed to the next presenter.
The next presenter is Dr. Ndalo Gammachu. He is currently assigned in Addis Ababa University in the School of Nursing and Midwifery Department. He served as a researcher as well as an academician. He has a nursing background and he did his master's degree in midwifery and reproductive health in Addis Ababa University. And his PhD, he's also obtained his PhD from South Africa in January 2020. He has over 25 years of experiences in various capacities. His research focuses on maternal and child health related issues and in modern family planning use, as well as he has also a research work on sexual and reproductive health of adolescents and youths, and on cervical cancer associated with human papillomavirus. He has published over 32 scientific papers in peer-reviewed reputable international journals, and he is involved in reviewed articles for many international journals in BMC in RH, BMC Human Health, and he is also an editorial board member of Pregnancy and Child Health Journal, and he is supervised and mentored over 40 postgraduate students working on their master thesis on the maternal and reproductive health related projects. So his presentation title is on the qualitative study of Ethiopian women's sexual experience and coping strategy for sexual problems after gynecological cancer treatment. So, Ndalo, welcome to present your presentation.
Thank you very much. Good afternoon, everyone. So I'm going to present this research work on the behalf of one of my advices are supervised in the 1920s. It's about human sexual experience and coping strategies for sexual problems after undergoing gynecological cancer therapy at Pambasa Specialized Hospital Oncology Cancer at Sabah University. Is a qualitative study. The topic is one of the neglected areas, so we'll proceed with that. Sorry. Here's the presentation outline. Sexuality encompasses sex, gender identities and roles, erotism, pleasure, intimacy, and reproduction. Cancer patients are frequently asexualized as they do not fit into traditional notions of sexuality. Nonetheless, for many people, sexual well-being is a significant aspect of their overall quality of life. Okay. Yeah, good. So sexuality encompasses sex, gender identities and roles, erotism, pleasure, intimacy, and reproduction. Cancer patients are frequently asexualized as they do not fit into traditional notions.
Sorry,
of sexual.
Ndalo, please summarize your introduction and pass to the main part. In the interest of time.
According to research studies, women with cervical cancer endure a variety of physical alteration to their vaginal anatomical and size. This alteration can cause women to have distorted body image and have conflict with their partners. In Ethiopia, cervical cancer is the second most common malignancy among women, and there are a rising number of long-term survivors for whom quality of life, including sexuality, is a top priority. So there is a scarcity of research on women's lived sexual experience and adjustment after cervical cancer treatment in Ethiopia. Little is known about how many with gynecological cancer deal with changes in their sexuality as a result of treatment, with what kind of sexual issues they have, how distressing they are, or how they deal or cope up with the problems. The purpose of this study was to explore women's lived sexual experience and coping strategies for sexual problems after undergoing gynecological cancer therapy at one of the oncology center in Black Lion Hospital. We used a phenomenological study design because we wanted to explore their experiences, shared experiences and stories related to these problems. We use purposive sampling strategies to recruit the study participants, and 13 eligible participants were interviewed face-to-face. So we approached 20 and 13 out of 20 accepted to be included in our study. So there are eligibility criteria to include them in the study. The data was collected in 2nd February to 15th March of 2019. We used thematic data analysis and following 3-stage data reduction, data display, and data conclusion. Critical approval was obtained from Addis Ababa University IBR, College of Health Sciences. So coming to the socio-demographic background of our study participants, as we have already said, 13 study participants were included in the study. The average age was 48, ranging from 25 to 55 years old. The majority of the women, like 10 out of 13, were married, and there were 3 single, having regular sexual partners. All of the study subjects were given radiation therapy, including other therapies. The average period after treatment was 5 months, ranging from 3 to 9 months after therapy. We identified 4 themes, which is resulted from in-depth interview data. Treatment side effects, sexual issues following radiation therapy, lack of awareness regarding cancer treatment and sexual dysfunction, and coping strategies. Under the coping strategy, we further identified 3 sub-themes: avoiding sexual intercourse through negotiation with their partner or husband, praying for healing, and seeking professional help. Later on, we'll just see some of the stories obtained from the participant. So just to share with you some of the stories there. One client said, 3 months after starting cancer therapy, I was uneasy because I experienced a burning feeling when urinating in vaginal discharge. As a result, your sexual being does not exist. Everything comes out, and I had to go to the bathroom now and then. So how do you anticipate having sex with your husband? So she asked this question. I had uncomfortable feeling and itchiness all the time for months. So it's almost some stories related to the drug side effects or the treatment side effects. As a result of their therapy, the majority of cancer patients in this study reported having sexual issues. It could be physical, like vaginal dryness, discomfort during sexual intercourse, or it could be psychological or emotional issues, anxiety during sex, like decreased sexual interest, body image, or even sometimes loss of femininity, all of which are consistent with the previous studies. So sexual issues following radiation therapy, some of the stories are here in the box. One client said, during sexual intercourse, as a result of excruciating pain, there was no climax. So you are not a fan of sexual activity. I'm hopeful that after the treatments offer, things will improve. Another client, I did not want to have sex after treatment because, as I previously indicated, I would start bleeding during intercourse, which was unpleasant, and that's why you rarely had sex. So all the stories, this finding is in line with Clary and his colleagues, which found that gynecological cancer patients reported determinantal alterations in sexual relationship and sexual performance, as well as sexual dysfunction at all stages of their sexual response. Cervical cancer patient receiving radiation therapy. So the third theme we identified is lack of information from the healthcare providers, nurses, gynecologists, and others. So here we can see some stories about their stories, like I was unsure whether or not to engage in sexual activity while undergoing treatment. No one ever asked me about my sexuality, and I'm embarrassed to bring up the issue of sex. It did not seem essential to me. We require assistance from clinicians to manage sexuality issues that arise as a result of cancer diagnosis and treatment. However, none of them brought up the subject of sex as part of their care for me. So again, according to a previous study conducted by this fellow, over 85% of nurses believe that discussing sexuality with patients is a taboo and private topic. This improper attitude and beliefs about the sexuality of their patient by nurses and may become a barrier in assisting carer patient in managing the sexuality problem induced by cancer and therapy. Healthcare personnel must overcome several challenges to improve cancer patients' quality of life, including their sexuality. Providing and discussing information regarding sexuality concerns with patients is one of the most important steps that healthcare professionals, including nursing, should take. Oncology nurses should proactively detecting and assisting cancer patients with psychosexual issues. Nurses should also be aware of and comprehend psychosexual issues to offer good care for cancer patients and survivors. Healthcare providers may be able to assist patients with their psychosexual recovery. When healthcare experts legitimize sexuality issues in a therapy setting, it allows individuals and couples to discuss them on their own. This could lead to more open discussions and about sexuality issues, as well as a reduction in marital conflict and sexual abuse. The last theme is coping strategies. So shortly, we identified 3 coping strategies. One is negotiating with a partner to avoid sexual intercourse, praying for healing, positive social support from husband or partner, seeking professional help. These are the coping strategies we have identified in this study. So just to mention some stories of our client, I informed my spouse that I had a problem with low sexual drive and that I needed him to realize that I was sick and no more sex. After this negotiation, we decided to put an end to it, meaning intercourse. So the second story is similar, so let me jump to the third. Any illness, I believe, is a gift from God. Thus, it is outside of my knowledge, but I need to keep praying and reminding myself that nothing is too difficult for God, because my body is His. I can accept it if He wishes to affect my private part. If God so desires, He can heal me of this fatal condition. My responsibility is to continue praying until His visitation day. I thank God that my spouse completely understands me when it comes to sexuality. If I'm feeling okay, I would meet his sexual desires one day. This is her story, one of the clients. The last is
Sorry,
professional assistant.
you are left only with 3.
I'm just closing.
Okay.
I'm closing. So in this study, some women focus on solutions and utilize conforming tactics by changing their sexual habits to cope up with the spouse's sexual needs. To deal with sexual problems, many of the participants adopt various avoidance techniques. Some women say they avoided tricking their husbands into penetrative sex by declining intercourse in subtle ways, such as having open and honest dialogues about their sexual relationship with their husband or partners. In this study, some women believe that cancer is a test from God, putting their faith and patience to the test, allowing them to impress their illness. This finding is consistent with other non-Western literature that has described spirituality and religion as coping methods that allow patients to follow their illness natural course. In conclusion, this study is the first of its kind in Ethiopia, and it has broadened perspective on sexuality in the setting of gynecological cancer and challenges certain commonly held beliefs about sexuality after cancer treatment. Sexuality is typically overlooked in clinical setting when it comes to gynecological cancer treatment in the study area. Providing and discussing information regarding sexuality concerns with patients is therefore imperative. Researchers should look into how inclusive sexuality education and training may be better integrated into the training program of healthcare professionals with regard to gynecological cancer treatment. More research is also needed to learn how partners of women with gynecological cancer cope with sexual challenges after treatment, how the couples as a partner negotiates changes after treatment, and the facilitators and barriers that healthcare providers face when discussing sexuality issue with patient requires further studies. Thank you very much. Any question, anything you want to ask?
Thank you, Ndale, for the nice presentation and timely completion. So we will come for the questions next.
Yeah, good.
The next presenter is Mr. Getnet Ayaleo. He is an assistant professor of University of Gondar, College of Medicine and Other Health Science, Department of Medical Microbiology. He holds a BSc Medical Laboratory Technology and MSc in Medical Microbiology from Gondar University, and has published 15 articles in peer-reviewed journals, and he is working on 4 additional papers. His research area is on biomedical science studies of infectious and non-infectious disease. He received various training in his area of specialty. So his topic of presentation is seroprevalence of hepatitis B virus, hepatitis C virus, and syphilis, and the associated factors among female sex workers in Gondar town, Northwest Ethiopia. So Getnet will come to present your. Getnet, only you have 10 minutes.
Okay, thank you, Mr. Shen. I think I will use my time properly. So as it is already mentioned, I will present the seroprevalence of hepatitis B virus, hepatitis C virus, and syphilis associated factors among female sex workers, which is done in Gondar town. So as you know, that sexual transmitted infections are a group of infections that are primarily transmitted by and protected sexual contract, or which are public health important and causes infertility, public inflammatory disease, cancer, and congenital infections. Due to their work circumstance and sexual practice, and in the position, an unfortunate position to negotiate safe sex, female sex workers are vulnerable for the transmission of sexually transmitted infections, including hepatitis B virus, hepatitis C virus, and syphilis. So the 2 viruses causes 86% of the viral hepatitis, and it can lead to cirrhosis, hepatocellular carcinoma, and liver failure, and they cause high acute or chronic infection, and as well as they contribute to a high rate of mortality and morbidity. They are the major global health problems for including the low income and high income countries, including sub-Saharan Africa. And the syphilis, which is a disease caused by Trichomonas pallidum, is a causative agent for syphilis. It's a gram-positive bacterium that causes sexual transmitted infection, and also many organ failures. So it can be including that hearts and brains. The main route of transmission is sexual, maternal, fetal, and blood transfusion, and rarely there are some mode of transmissions. So in 2016, WHO estimated that 6 million cases of syphilis, mostly seen in Africa, So the majority of the sexual transmitted infections shares common route of transmission, prenatal route of transmission, unsafe sexual transmission, and sexual practice, and vertical transmission mother to child. So viral hepatitis are 100 times more contagious than other sexual transmitted, specifically HIV, and the prevalence of this sexual transmitted infection is believed to be higher in general, female sex worker than general populations. In Ethiopia, it's estimated that 0.6% for hepatitis C virus infection, 12.5% for syphilis, and up to 31% for hepatitis infection in female sex workers. So lack of access to regular screening for sexual transmitted infection among female increases the disease transmission in resource-limited countries, including Ethiopia. Age, income, inconsistent condom use, contaminated sharp and breathing materials, condom breakage, use of stimulant drugs for sex, and the lack of treatment and training on STIs are some of the main factors that contribute for the transmission of this sexual transmitted infection for females. So the significance of this study was due to, okay, I feel so little slides.
Pass to the methodology. Time is.
So when you come to the methodology, the study area is Gondar town, which is far from 745 kilometers from Addis. And Gondar town has more than 60 hotels, 76 bars and restaurants, and more than 28 modern or cultural nightclubs. And the study was conducted in Gondar. A cross-sectional study design was employed, which is done from March up to June 2021 among female sex workers. And the sample size was determined by a single population proportion formula, which is taken by 30.1% from the previous study. And a total of 194 female sex workers who was included using this novel method. So we collect blood from, first we use standard questionnaire for the demographic and behavioral and other predisposing factors. And we took blood from the patient using, female sex workers by using vacunar tubes, 5 milliliter of whole blood, and transport to the blood bank and centrifuge the blood and store the serum at -degree centigrade until the laboratory ELISA test was performed. So ELISA test was done to screen for the presence or absence of hepatitis B surface antigen, anti-hepatitis C virus antibody, and anti-syphilis antibody. So we adhere all the qualities, the pretest assigned a special codes and double checking for the questionnaire, and standard operational procedures was employed, and standard positive and negative controls was performed, and all positive samples were repeated. So ethical approval was obtained from the School of Biomedical and Laboratory Science, the College of Medicine, and University of Gondar, confidentiality by using code. So we give codes for all the samples and the questionnaires. So data were entered and analyzed using SPSS version 21, and logistic regression was performed. So when it came to the result and the discussion, we include 194 female sex workers, and the mean age was 26.81, and 2/4 of the female sex workers were aged between 25 and 34. So about 98 or half of the female sex workers were single. So when it comes to the prevalence, as you know that hepatitis B virus endemicity is classified according to the WHO Health Organization. The Ethiopia is categorized in high or medium high endemicity. So when you look on the prevalence on female sex workers, so we found 12.8% of hepatitis B virus seroprevalence, and this is similar to different studies, which is done in DSE, 30.1, 12.6 in Central Uganda, and 40.4 in Argentina. And this was also higher than studies which is done from Mekelle, Italy, which is 3.5, and Rwanda, 2.5. And this was also lower than from Brazil, which is account 23.1%, and Burkina Faso, 80.2%. So when you, the main reason for this discrepancy is believed to be that the endemicity of the hepatitis B virus infection, the social demographic and associated risk factors. So the endemicity is different between nations and nations. So also significance influenced by the screening, training, treatment, and prevention programs of the nation is dependent. So additionally, the prevalence of hepatitis B virus and the influence by sample size, sampling techniques, also laboratory techniques. Okay, so when you look for the hepatitis C virus, it's reported that Ethiopia, the hepatitis B virus prevalence is ranged from 0.8 up to 2%. So when you look on female sex workers, which found we found that 6.7% of hepatitis C virus infection among female sex workers. So this is similar to that of Burkina Faso, which is 10.6%, China 7.1%, Brazil 8.8%. And this is higher than the DSE 0.6%, Brazil 0.9%, and lower than our studies, lower than South Africa, which is 60%. Also, all factors that are which are works for hepatitis similar works for hepatitis C virus. So the socio-demographic and socio-economic factors significantly influenced by the screening, treatment, and prevention programs of the nations. So this is similar to that of the hepatitis B virus. Perhaps they have a common route of transmission. So when it comes to syphilis, so look, we found that 12.3% of syphilis antibody was found in these female sex workers, and which is similar to that of the previous study, which is done in Gondar, 10.9, and Brazil, 40.14, and it is also higher than the public from Republic of Congo, which is 2.2, and lower than the Rwandans. So even though the factors for hepatitis B virus and hepatitis C virus are the same as those for syphilis, laboratory test might be the key difference in this prevalence rate, because rapid test was done in a Rwandan test, but we use one step advanced technique, which is ELISA test for our study. So when it comes to associated factors, we determine different variables for this, but unfortunately we show some association for a few variables. Like inconstant condom use was found to be twofold of hepatitis infection compared to those of who did not who did use condom constantly, and the prevalence of hepatitis C virus infection and syphilis was 10 and 70 times higher in female sex worker, did not always use condoms, respectively. So our finding, along with the findings of those other studies like Mekelle, Hawassa, and Brazil, in constant condom usage during sexual activities increases the risk of contracting sexual transmitted infections. And when you come to this, the female sex workers who use sex stimulant during sex, they have the chance to 15-fold higher hepatitis C virus infection and 20% higher syphilis infection, respectively. So, drug, the sexually drug use is a term which is described for stimulating sex, which is commonly used in men's, particularly men's for sex with men. Countries like USA, Asia, and some European countries impact on the trends of this sexual transmitted infections. So, okay. So this might have the contribution for the transmission of this. So additionally, effects during genital ulcers were 6 times more likely to be contract HIV infection, HCV infection than sex without genital ulcer. And females who have kids had 4-fold higher risk for contracting sex than female sex workers. I think for time being, the overall, our finding shows that comparably higher prevalence in hepatitis B virus, C virus, and syphilis. In constant condom usage was common variable that shows associated with viral and syphilis infection. Variable like sex stimulant drugs, having children were significantly associated with the following infections. Regular screening and giving preventive drugs are recommended. Giving attention to the regular screening for female sex workers could have potential in controlling the transmission of this infection, and hepatitis B virus and hepatitis C virus syphilis test in empowering surveillance are mandatory. So our findings have a little limitation because we are not able to do molecular tests because of budget limitation. So I would like to acknowledge all the study participants in Medical Biomicrobiology Department, School of Biomedical, Central Gondar for the Health Bureau, Gondar Town Police Office, Marbury Youth Association, Central Gondar Blood Bank, all data collectors. These are some of the reference, and I would like to thank you.
Thank you, Ketan.
So our last presenter, Mr. Nagash, is not around, so we will proceed to the questions and answers with our presenters. So now the floor is open for questions and answers. Okay, 1, 2, 3. So let's start with the 3 and we will proceed for the next round. We only have 3 more spots for your questions. So the first one.
Would you make it clear, please? Okay.
Thank you very much. First, I really want to appreciate those presenters for a very excellent presentation as well as the areas that you tried. The areas that you tried to touch is quite important, and it needs to be studied very well. So I really want to congratulate you on selecting this area of research. And particularly my question goes to the second presenter, Gupinath. So have you tried to analyze, a pattern of age, how hepatitis B and syphilis is affected on age, as aging progresses? Because you included the pattern of age starting like there is a broad spectrum of age. So have you tried to analyze this incidence or prevalence of this infection is different across different age groups?
The third question goes for Abel, and I will come. Abel. በእድሜ አድርጎት መሰለኝ።
Okay, thank you. So my question goes to Mr. Ndalo. Do you think your study populations are uniform? When you mentioned the treatment, you said radiation plus other treatments. So are your study participants uniform? Because some of them may take radiation, some of them may take surgical intervention. So the two groups may not be comparable. And the other, did you try to ask their sexuality before the treatment versus after the treatment? Because some of the cases on your study, they say their sexuality is affected due to the presence of the bleeding, vaginal bleeding. So did you try to assess and compare before treatment versus after treatment? Thank you.
Thank you, Dr. Betel, for giving me this chance. My question goes to the last presenter. You have said that use of drugs and having children were associated with these problems. So what's the nature of the association? I mean, using drugs, we expect to expose them more for these illnesses. On the other hand, probably having children, we may be motivated to use protective things like condom, use of condom and the like. So what is the exact nature of the association? Similarly, you have said that almost 50% have partners as well. So this would be also another motive or motivational factor to use protection, like use of condom or negotiating for the use of condoms. So I want you to shed light on that. The other is an ethical issue. So you screen them for serious illnesses like syphilis, hepatitis B, hepatitis C. At least for the syphilis, for those who are positive, you should offer definitely treatment. And then on the same line, for those who are positive for hepatitis B surface antigen, they have to be automatically either provided or counseled to get the immunization. So I want you to shed light on these issues. Thank you.
Are there any more questions? Let me ask, I have already one of my questions has been raised by Dr. Derja for getting it. I will ask one more question for Dr. Ndalo. And thank you for addressing this quality of life of issue of a woman after gynecologic cancer treatment. There was an interview with the nurses. So have we tried to assess the knowledge of the providers about the treatment and its impact on normal physiology, psychological impact, and the social impact of the treatment that they are providing for the women? Because these providers, to counsel their patients, they should know them. They should have adequate knowledge about the impact of the treatment. And were you able to access the knowledge of the providers in that interview? Thank you.
Thank you very much. The first question was, did you assess the problem after or before we clearly stipulated in the methodology that we focused on after treatment. Even the title itself is self-explanatory. It says women's lived sexual experiences after gynecological cancer treatment. So the first question might be answered by another researcher maybe. Otherwise, we have considered women who have started gynecological cancer treatment, mainly radiation therapy, at the minimum of 6 months. 6 to 12 months, we consider the time period. Because during this time, she might have rich experiences with regard to the treatment and her own sexual experience with her partner. That's the assumption behind. Did you consider the staging? No. Regardless of their stage, we included all clients who are responsive to our invitation to be included in the study.
Sorry, let me take you back. I don't think the question was about the stage, rather the strata of the degree of their sexual satisfaction or experience during the interview. It's not about the degree of the disease, the stage of the disease, but it was that mild or severe or moderate sexual dysfunction
No,
we're having.
Understood. We did not even address that issue. Thank you. So the other thing, with regard to the study participant, are they uniform or not? They are all uniform. They are homogeneous in a sense that all had radiation therapy plus other treatments not related to cervical cancer treatment. Okay, medical treatment, medical issues. That's why we said plus, radiation therapy plus. So in the inclusion criteria, we emphasized radiation age greater than 18 years and participant consent. That's compulsory. And any radiation therapy to the cervical, to the vulva, or to any part of the gynecologic organ. Thank you very much.
Sorry, there are things that I feel like they were not addressed. On the second question, when Dr. Abel asked this question, the title says that it says gynecologic malignancies, but only patients with cervical cancer were included. So when we say gynecologic malignancies, we have a lot of patients with ovarian. Oophorectomy by itself has its own sexual dysfunction. Having radiation have its own sexual dysfunction. And then having radiation, chemotherapy, and surgery will have another impact in the treatment and outcomes in the sexuality of the woman. So the title was gross, but we only took 13 patients with cervical cancer. So even they could have been further classified depending upon the treatment they got. There are patients who already had surgery followed by chemoradiation. There are patients who directly sent for chemoradiation. And that stratification could have given us a clue for the impact of our treatment and the care that we deliver for our patients in the future care. But this will be a recommendation so that people who are willing to do this research in the future shall include this. Thank you. Mr. Gittin, you are lead.
Sorry, the knowledge of the providers, we gave the chance to be explored by the future researchers in the recommendation. Thank you very much, Dr. Betel. I'm not a clinician, I'm from the nursing background, and I did my PhD reproductive and sexual health. So I really appreciate your inputs. So we consider it as a limitation, the study limitation. Thank you very much.
Okay, thank you. For the first question, which is age-related pattern, we try to categorize the age depending on the World Health Organization age categorization, but we fail to get association with age. That's why I'm not presenting all the findings here. Only the associated factors which have significant relation with sexual transmitted infection was presented here. But in the main example portion, there is, but I think it's the fact that sexually active reproductive age groups are vulnerable for sexual transmitted disease. We found that age group 24 up to 34 were higher prevalence, but it is not associated with other infections. When it comes to the second questions, there are 3 questions, I think, or 4 questions. I will try to focus on in general ways, because for ethical purpose for the last question, we link all positive female sex workers to the health care facilities and for further management. Unfortunately, you know that there is no treatment for hepatitis infection, especially for hepatitis B virus. And little is known about the complications and so on and so forth. So that's why we implemented this study. And perhaps we did, before this study, we did studies on hepatitis B vaccine immune prevalence. So which is done in Addis Ababa, Gondar, Jimma, Mekelle, and other Hawassa, which was countryside large study. I was involved in my because of Ahari. So at that study, we did the effectiveness of the vaccine, which is given for hepatitis B virus. That's why we are focusing on hepatitis B virus in different populations. Also, we have ongoing research on prisoners and also other clinical setups like TB patients, HIV patients, and so on and so forth. But the main point is we plan to scale up our study on vaccine. We found that very little protection rate for the vaccine, which is 32.2% of protection for children who were vaccinated for the hepatitis B virus. But the WHO recommended that greater than 87% of protection level was expected from the vaccine. But we are focusing on that. So we are recommending that because of this, we are recommending that regular screening, preventive mechanisms, and so on and so forth. And according to that, when you come to the drug and having dependent children of female sex workers and parents, yes, drugs it's well known that stimulant drugs have effect on sexual transmitted infections because they stimulate, they use stimulant drug for stimulation of sex. So this can increase the risk of transmission, as well as having children. Perhaps it have a high rate of transmission because hepatitis, as you know, can be transmitted from parents from mother to child, vertical, or household contact also can be the factor. In our study, we get that factor, but different researchers are contrarily reported that having children have less associated risk factor than who have children. So this is because I think it's depending on the activity, the personal hygiene, and knowledge on the transmission route of those sexually transmitted infections of the household members, including the fathers or the mothers. Because some researchers are get lower prevalence and at the same time no association with those infections, but we found that association with female sex workers with children. This is all our.
So I would like to thank our presenters, and then for the active participation of the audience. Thank you. መድረኩ ስለተሰጠኝ ስልጣኔን ተጠቀሜ የሁለት ደቂቃ ገጠመኝ ልንገራችሁ። ምክንያቱም ይሄ ሴንሲቲቭ ኢሹ ስለነበረ ነው ዶክተር እንዳለ ያነሱት። የ68 ዓመት አዛውንት ናቸውና አድቫንስድ ሰርቫይካል ሲኢ ዲያግኖስድ ሆነው ኦፐረብል ስላልነበረ ኬሞ ራዲዬሽን ላክናቸው። ትሪትድ ሆነው ከመጡ በኋላ ለፎሎ አፕ እኛ ጋር ይመጡ ነበር። አራተኛው ወር ላይ እናትየው ደማች ተብሎ ልጆቹ አሯሩጠው አመጧቸው። ትልልቅ ልጆች ናቸው። ኒርሊ 50 ዓመት በትዳር ኖረዋል። አያኋቸው፣ ምንም ሳይንስ ኦፍ ሪከረንስ የለም፣ ግን ያው ስቲል የተወሰነ ብሊድ የሚያደርግ ኤሪያ ነበርና ለብቻ ሳወራቸው ምን አሉ ይመስላችሁ? ባሌ እኮ ነው አግባብየው ነበር እምቢ አለ። and then after those longer treatment period እና post menopausal impactን እያወቅነው ሴክሹዋል ኢንተርኮርስ ሲኖራቸው ደም ልጆቹ ግን ይሄን አያውቁም። በደሞ ቁጥር እኔ ጋር ይዘዋቸው ይመጣሉ። ፋይናሊ ያለን አማራጭ ኢስትሮጅን ክሬም መስጠት ነበር። ሰውየው ሌላ አላገባም አሉ፣ ሴትዮዋ ብሊድ ያደርጋሉና ብዙ ነው ላይክ ልጆች ኤቭሪ ታይም ይሄ ሃፕን ሲያደርግ ሪከረንስ የመጣ እየመሰላቸው ይሳቀቃሉና ብዙ ገጠመኞች አሉና I think this is the area to investigate and to work more. Thank you.